Hello everyone, it's Claire Snowden here to chair the session today. We're going to have Anna Kearney talk today about a really interesting and very relevant topic to lots of us about the sort of communication and withdrawal and retention topic in patient information leaflets. So that's quite an interesting sort of angle to take on patient information leaflets. Before I start, I'd like to do just a little bit of housekeeping. I'd like to mention that today is going to be the last webinar that Chris and I have organised and that I will chair. So I want to make sure you're aware of the next steps. So I'm sure you're all very much aware of the change from the HTMR to the Trial Methodologies Research Partnership, TMRP. And because of that, there's going to be a restructuring of the webinar series. So it will no longer be run by the trial conduct group, but it's going to be centrally coordinated. So it's been really nice to run these sessions, and thank you so much for being so engaged and such a sort of constant audience that often asks questions. So I'm sure you'll be able to do the same with the upcoming webinar series. We don't have details yet as to exactly when the first webinar will be. I'm sure you'll get more details through the TMRP newsletter and website. So if you want to know, you could check out those places. But for now, I'd like to introduce Anna Kearney, who's, as I said, going to talk to us about patient information leaflets. And it's something that I'm particularly interested in, so I'm keen to hear it. The question that she's going to address is, do they help participants understand the importance of completing clinical trials? She's a clinical trial methodologist at the Liverpool Clinical Trials Centre and started working for University of Liverpool as a trial coordinator assistant 7 years ago to help set up a pragmatic trial in epilepsy, also researching delays in opening sites. Since that time, Anna's undertaken several methodological research projects around trial conduct and delivery. She's got a special interest in recruitment and retention and has spent the last few years coordinating the development and update of ORCA and ORCA2 databases. And we've heard about that several times. She's been our most regular speaker in our webinar series. This will be the third time Anna's spoken to us. So if you want to check back on her previous webinars, you can find recordings on our website. So you'd need to look back at December 2016 and September 2018 and put them together with this one when it becomes available. You'll be able to have a trilogy of Anna webinars, if you would like. So Anna, I'll pass over and we'll take questions later. So if anybody wants to be putting them in the chat box, we can pick them up later on. Thank you.
Brilliant. Thanks, Claire. Thanks for the introduction. So as she said, we're going to be looking at patient information leaflets today, and do they help participants understand the importance of completing clinical trials? The work that I'm going to present was part of a wider project on participant retention within clinical trials. And I always like to start with a bit of definition about retention because it can vary across, it can vary for different people. So what I mean by retention is all randomized participants remaining in the trial to study end and contributing outcome data for the analysis. So we're looking at patients staying connected with the trial, but also making sure that they continue to contribute outcome data whilst they're connected to the trial. Also, to give you a bit of a background about why retention matters, I'm sure a lot of you are very familiar with this, but you know, there's a lot of time spent within clinical trials trying to recruit participants to trials, and a lot of our metrics and our incentives around recruiting participants to time and target. But these are wasted if those participants are not retained and do not contribute outcome data. Because if they don't, that can lead to, oh, hang on, it's not going, there we go, a reduction in the power of the study, as you would do if you don't recruit enough participants, but also a problem in interpreting the results if there's different missing data across different arms or different reasons for missing data. And this can basically make it very difficult for your trial to really assess the treatment effectively. So briefly as well, how big is retention an issue? Well, it is quite difficult to estimate this because of differing definitions, like I've said before. but we can see that it's generally between about 5 and 20%, depending on the different types of trials and different definitions. And obviously there's different discussions around how much is too much, but what we do know is that actually addressing retention is one of the top 3 methodological research priorities. What we also know from some research that we've done with chief investigators of HTA-funded trials is that patient withdrawal and patients losing contact with trials are the biggest causes of missing data. They affect most trials, and therefore it's really important to be looking at what we can do about it. In a lot of previous work I've done, I've looked at different retention strategies, and from that we know that a lot of strategies are aimed at trying to improve and influence participant behaviour. I hear someone saying they can't hear anything. I hope everyone else can hear things. I'm going to continue until someone tells me they can't.
Just to reassure you, I can hear perfectly. So
brilliant.
I think
okay.
Maybe it's somebody's own particular issue. I'll
Brilliant.
go on mute again.
That's fine then. I'll carry on. Okay. So we know that a lot of retention strategies aim to try and influence participant behaviour, like they might be incentives or newsletters, or they may be taking lots of contact details to keep participants, keep contact with participants, sending birthday cards, things like that. But what we started to notice was very little research that seemed to focus on participant education around the value of retention in trials. And so we were interested to think about, are patients aware of the importance of retention? Do they know how dropping out of a trial might affect a trial, given that a lot of participants get involved for altruistic reasons? So this was the aim of our study, was to understand if and how retention is described to trial participants within patient information leaflets. We appreciate that patient information leaflets are only part of a consent process, but this was something that we could look at and measure, and something we felt that actually should have some content about retention, because it's something that the participant can go away and take away and look back on and read. So it should contain core information for trials. Worth noting, I believe, that Katie Gillies from Aberdeen has done some work on the actual conversations and has found similar results to us about the level of content of retention as well. I'm not sure if that research is published, but I'm sure you can contact her if you want more details on it. The research that I'm going to present was published a little while ago and was done a little while ago. So I've included this slide because I wanted to highlight that it's actually still incredibly relevant, which is why I've suggested doing this webinar. Some of you will know about the Priority 2 Retention Research Priorities project that looked to identify key research priorities to address retention. And it came up with the top 10, and I've picked out 4 of the top 10 that I think are relevant to the work I'm going to talk about. But most relevant is point 9 there. Their 9 out of 10, ninth research priority was what information should trial teams communicate to potential trial participants to improve trial retention. So we know that this is still a really hot topic, and hopefully one that'll be of interest. So in terms of what we did, well, we created a patient information leaflet content checklist based on the HRA guidelines at the time and GCP guidelines. So this was done a little while ago, and literally as we were publishing it, they updated their guidelines. But essentially, the content is very similar. And so we took a whole list of content that should be included, and that's just a few examples there, such as trial title, research purpose, risks, benefits, trial treatments, what taking part involves. And there's a much longer list, you can see that in the publication, of what we looked at and what we decided that we needed to check these patient information leaflets for. But on top of this, we also added additional retention-specific questions, such as, does it state that participants should be willing to have any assigned treatment? Does it explain the importance of retention? And does it distinguish between withdrawal from treatment and withdrawal from follow-up? Because that is quite a challenging area, and I know from experience that actually withdrawal can be used interchangeably to mean different scenarios. So we were keen to see what the patient information leaflet said about those things. As this was part of a wider project, we took a cohort of trials that were funded by the NHR HTA and were starting between 2009 and 2012. We were looking for trials that had already started, that had recruited and were already dealing with sort of retention issues. So this work was probably started in about 2015, 2016, but we were looking for trials that had been running for a few years. So we started with 159, and because it was part of a wider project, we focused on parallel trials that were 2 arms, phase 3 or later, and that were main trials. If they had an internal pilot, they were still included, but we did exclude just pilot trials because obviously the issues might be different. We found 75 eligible studies, and then we set about trying to identify the patient information leaflets for those 75 studies. All the protocols were available on the website, and some of the patient information leaflets we got from protocols, some we got from study and CTU websites, and some we got from contacting the studies directly. Where we obtained more than one patient information leaflet, we tried to use the most recent adult version of prospective consent. We found 50 trial patient information leaflets and their corresponding protocols. So when we looked at the results, what we had from those 50, we had patient information leaflets that were written between 2008 and 2014. They varied quite a lot in terms of the content and the number of pages, between 2 and 18, with a median of 5. And as you can imagine, they got longer as time went by. In terms of the protocols, again, there was quite a variation in the length. There was between 14 and 196 A4 pages. And in terms of the studies that we were looking at, 3 out of the 50 were deferred consent. 15 out of the 50 were evaluating one-off treatments. They covered a range of intervention types. Just over a quarter of them were drug or CTIMPs, but there was also a lot of representation of device, surgical, behavioural and other types of interventions. And again, you can see they covered a range of health categories, with mental health and orogastrointestinal as the most frequent ones. So when we looked at the content of the patient information leaflets, we saw that patient information leaflets were very good at adhering to the kind of core HRA content. 100% described the trial treatments and the trial procedures to be followed. 96 communicated the duration of the subject's participation. 94% communicated the risks, and 90% communicated that the participant or their doctor would not determine the treatment. Interestingly, only 26 were explicit about that, and the remainder implied by using statements such as a computer will choose your treatment or it will be chosen by chance. 70% described the probabilities of getting each treatment, and interestingly, only 10% stated how patients and public were involved in the study. However, I think that figure would probably be slightly higher if we were using a more recent cohort. When we looked at the actual retention statements and what was included in the patient leaflets around withdrawal and retention, we saw that patient information leaflets were very good at containing content on a participant's right to withdraw. They all included a statement on it, as you would expect and you would hope. They varied slightly in the wording of that, but the majority said you could withdraw at any time, with slight variations around phrases such as withdraw without giving a reason and withdrawal not affecting the standard of care. What these studies were not so good at communicating was that actually they may ask the participant for a withdrawal reason. Only 6 studies included that within their patient information leaflets. And when we went to look at the protocols, we found 19 protocols stated that they were collecting withdrawals. So there was quite a mismatch there. And as we've been working on retention, we have found that there can be a misconception as to whether you can collect withdrawal reasons from participants. But actually, ICH GCP 4.3.4 says, although a subject is not obliged to give his or her reasons for withdrawing prematurely from a trial, the investigator should make a reasonable effort to ascertain the reasons while fully respecting the subject's rights. And I guess this is important because understanding the reasons helps us understand whether there's any potential for bias or any larger problems in the trial that need addressing. And these are some of the statements that 2 of those 6 gave around this. They said, you do not have to give a reason why you want to stop, but this information can be helpful because it helps us identify problems with the study and areas for improvement. And another study said, withdrawing from the study will not affect your child's medical care. We hope, however, that if you do withdraw, you would give us a reason and will allow us to continue collecting information from your child's clinical notes. This will help us when we look at the results of the study. Looking more broadly at content about retention, we looked for any content that explained the importance of retention, and we found that only 16% of studies included something. And we'll have to say we were quite desperate to include anything here. We were looking for any statements that said it is of value, it is of importance, it is helpful to remain in the study or provide data. And here's 2 examples of what we found. It is very important for you to answer all the questions in the questionnaire for us to accurately assess the impact of the treatment upon you. And another study said, in order to produce reliable results, the research centre would like to receive information on you for at least 10 years following completion of your treatment. So these are very subtle statements, but they do kind of give a sense of importance of continuing to provide data and contribute to the trial. Interestingly, found that only 6% of the prospective consent trials, so that's 47 trials, stated that patients must be willing to have any treatment to enter the trial. Now, this was quite an interesting one, an important one, because I'm sure we're all aware that participants can have a preference for treatment, and they can join a trial with a view that if they do not get their preferred treatment, they will then drop out. And in fact, I've even heard sort of clinicians and recruiting staff say, well, okay, yeah, you have got that preference, but don't worry, sign up. If you randomise and you don't get the treatment, you can drop out. But actually that can be quite detrimental and harmful down the line, and is not something to be encouraged. So we were quite surprised that this did not feature more regularly within the patient information leaflets. When we looked at the protocols, we found that 86% contained information on withdrawal, which sounds very positive, but that's 14% that didn't include anything. And when I say anything, literally nothing, because a proportion of those 86% merely reiterated the participant's right to withdraw. They only contain basic GCP content, that a participant has the right to withdraw without it affecting their care, and that's all they included. They didn't include any further comment on specific withdrawal processes or other things. And we also found that 46% stated that the trial wanted to continue to collect follow-up data if a participant withdraws. So this was interesting, again, because they said they used the term withdrawal, but they were still wanting to collect follow-up. And for me, this highlights that actually there's some challenges around the use of terminology, and it might be worth us considering reserving the term withdrawal for when a participant stops all study involvement, and using other terms like stopping treatment or stopping some modes of data collection in order to give some clarity around this. Because a lot of trials were trying to make the distinction that they did want to still continue following up data where possible. Okay, we also looked and tried to compare information across the patient information leaflet and protocol for a few different areas. And the first one here was data collected before withdrawal. Now, it's worth noting here that this was all done pre-GDPR. So I suspect if we did this same analysis on patient information leaflets and protocols post-GDPR, we'd find very different results. But I put this in here because I do think we do need to be thinking about, when we're writing our patient information leaflets and our protocols, being clear about what we do with data that is collected before withdrawal. Okay. So at this point, a while ago, we found that sort of 38% didn't mention it at all. And where it was mentioned more frequently in the patient information leaflets. At the time, we also looked at whether the trials offered patients the options of deleting data. We knew that the FDA at the time didn't allow it in their trials, but we could see that a lot of trials here were offering it, and we wanted to see what the extent of that was. Again, 62% didn't offer it at all or didn't mention it, but again, where it was mentioned in the patient information leaflets more frequently. And obviously no one explained that deleting data would impact on the results and would cause problems with the analysis. We also looked at how the patient information leaflets and protocols talked about options for follow-up. When participants are within trials, they can have problems. There may be a sense of study burden, and they may have problems kind of adhering to all the clinic visits, different questionnaires. We often have a lot of data collection in our trials these days. And we were interested to see, do studies offer any alternatives to full withdrawal and stopping it all? Do they offer some sense of, well, if you're having problems, perhaps we could reduce the number of questionnaires, or perhaps we could just collect routine data or just use data from national records? And we can see here that 66% of studies didn't include any of this information in their patient information leaflets or protocols. Where they did offer it, studies seem to offer more around continuing with routine data collection, but there was some options for national records and stopping trial-specific questionnaires. And this is something that we'd look at and we'd consider recommending going forward, that protocols should certainly include some options for trials around what to do if someone is feeling burdened by the amount of data collection or the amount of follow-up, and what those options are, because at the moment site staff wouldn't know what to do, and they therefore might presume full study withdrawal. So it's worth thinking about what is in your what is in your protocols, and whether it's also of benefit to include some of this information in your patient information leaflets. So in the paper that I'm going to show you in a minute, what we did was we took some of this information and we came up with 5 recommendations. We're very aware that, the argument is that patient information leaflets are getting longer, they're getting more complex. It's possible that participants don't even read them, they lose them. They may not be as effective as we'd like them to be. But we do feel that it is important that patient information leaflets do contain some information on the value and importance of retention, particularly if there is a lot of content about their rights to withdraw. That needs to be balanced with some information on the benefits of staying in the study, so that participants can make a really, truly informed decision about participation at the start of the trial, but also about ongoing participation. So these are some recommendations that we thought that might be easy ways to address some of the things that we found, whilst keeping it short and simple and sweet. And the first one we put in here was to emphasize the need to talk to clinical care team at an early stage if problems emerge. And this isn't a statement that we've tested with participants, but it is just an example of something you could include. So it says, for example, if you develop any concerns over participating in the trial, please talk to your doctor or nurse to discuss these and the different options available to you. And we felt this was quite important because if with the patient information leaflets containing so much information about the right to withdraw, it would be very easy for participants to decide to withdraw as soon as there's any problems or challenges. And then the first point you hear of this is them saying, like, I want to withdraw. And that can be then difficult to discuss different options and to discuss why participants are wanting to withdraw, because it can feel like coercion. I'm not saying it is coercion, but that's what some people might feel like they are coercing participants or trying to change their mind. But if we can encourage those participants to come to the research staff, the research nurses, the research doctors at an early stage and highlight any problems, then that allows for much more open discussion of alternatives that may address those problems. Secondly, we thought it's important that the information sheets informed participants that we may ask them why they want to stop taking part and why this information will be helpful. If we only say that they don't have to give a reason, it then becomes quite a shock and perhaps slightly offensive when we do ask them for a reason. We need to balance, again, those two bits of information. Thirdly, we need to explain that patients should only take part if they're willing to accept any of the trial treatments, which we discussed before. And then fourthly, we need to clearly describe participant withdrawal, making the distinction between premature discontinuation of treatment and stopping all study involvement or study withdrawal. Now, that clearly isn't a statement you would put in the patient information leaflets, but essentially what we would want to encourage is for you to go back when you're writing your patient information leaflets and look at that content and think about what you mean by the term withdrawal. Is it clear? Talk to your PPI people who look at your patient information leaflets. Make sure there is some statement that helps people understand that if they do need to stop treatment early, that it is of benefit to stay in the study. You know, I think as Claire said, I've worked in trials methodology for a few years. Before that, I worked in a different sector. I understand the intention to treat principle. I understand why it's important to have data when you're not receiving the treatment. But I don't know that that is intuitive to your general participant. You know, from my perspective, or I could certainly understand from a participant's perspective, you might think if you stop taking the treatment, if I give you my data, it may actually make the results wrong. You know, if I'm not taking the treatment and I'm getting better, well, that will tell you something wrong about the treatment. So actually, we need to start thinking about how we can help people easily understand if they have to stop the treatment, then they should continue within the study, and that is still of benefit. Fifthly, explain the value of data collection and highlight any options for unobtrusive data collection through routine records. That should certainly be in your protocols, but it's certainly something that's worth saying in the patient information leaflets as well. So those are our 5 recommendations, and I think this was all included in the paper that we published in PLOS One in 2018. So that all the data's there, you can go and see it. And if there's any questions, feel free to ask them now. I whistled through that quite quickly, sorry.
Thank you, Anna. There was an awful lot in there and lots of things that we can start to unpick. Please, anybody, if you would like to speak and you have access to a microphone, you're very welcome to put your questions directly to Anna and to start a discussion. For anyone who doesn't have a microphone or prefers to chat, you can put your questions in the chat box and I can read them to Anna. She can't see them directly, and we can make sure that we get some sort of discussion going. So please do put some comments in there if you would like to discuss this. There's one sort of really obvious thing, Anna, that maybe I can raise, that you're talking about including additional information. It sounds like for very good reasons and for sort of patient benefit as well as for the trial. But of course that will lengthen leaflets that are already in some cases quite long. Do you have any thoughts about the impact on the length of the leaflets?
Yeah, I think it's a challenging one. I think one of the reasons that I included sort of the background as to the extent of retention and why retention is an important issue at the beginning was because, you know, it's clearly evident that it is a big issue for trials and it's an important thing to resolve. So from my mind, you know, this is an important issue that does warrant thinking about how it is featured in the patient information leaflets. Because we do need to kind of look at how we're addressing this and look at how we are communicating participant withdrawal. I think what I would say is that I think for patient information leaflets, I think there will be short, simple ways we can sort of highlight the value of retention and staying in a trial, just to balance out the kind of emphasis, the current emphasis on participants' right to withdraw. And I think that is needed, but I think it's a case of finding just short, simple statements. And hopefully some of the statements that we've highlighted here to give you ideas about that. There's a few more in the paper itself, and there may be some that you can come up with your PPI representatives. So I guess what I'm encouraging is they don't have to be long, lengthy, big blocks of sentences, but they'll just be bits you can be dotted in just make sure we're explaining things in a balanced way.
Thank you. We do have a question that's come in, which is about feedback from the Ethics Committee. Have you had any feedback on the request of the reasons to obtain a withdrawal reason from the participants? And can you share some of the challenges?
I personally haven't, no. I think most of the work we've done is talking to researchers, and we've had various, we've had people say, oh, you can't ask that, and there's other people saying you can. I think if it got raised by an ethics committee, I would point them to the ICH GCP that I put up on the slides, because GCP does say you can ask and you should ask, obviously sensitively and respecting the rights that the participant doesn't have to give a reason. But it's clear in ICH GCP that it should be attempted in an appropriate way. So I haven't had any negative comments from ethics, but there may be other people that have. But I guess I would encourage people to just push back a little bit on that and reference ICH GCP.
Okay, that's good advice. So Manit's added that for their study, she said, we did have ethics approval for asking for withdrawal reasons, which is documented by our clinicians. So that's an interesting comment directly from practice.
Yeah, I think if they are saying no, I think I think there is quite a lot of misunderstanding around this area. So I think it's just trying to clear up that misunderstanding and help educating people.
Yeah, and that point about misunderstanding has actually just been picked up by Lucy. She focuses exactly on that, saying, I found that sites are often confused about the nature of withdrawal as well as the patients, and they sometimes pass on that misinformation to the patients. So maybe a parallel piece of work to do is to understand what the site's contributing and the site's recruiting understand withdrawal to be.
Yeah, and I think this is where we focus a lot here on the patient information leaflets and kind of cross-referencing it to the protocols. But actually, I think there's also a lot of work that can be done on the protocols, because if all these withdrawal processes and clarification of the term withdrawal are not included in the protocol, sites aren't always aware of what they need to do. And in a lot of cases, they presume full study withdrawal because it's just easier if they're short on time. They just tick everyone as withdrawn and not actually aware of the need to stay in the trial. And I've also heard a lot of people comment that actually research site staff aren't always aware of. I talked about the intention to treat principle of still collecting data for participants who've stopped a treatment or didn't receive it. I think a lot of site staff aren't always aware of that either, and so it's also important to think about, if that is the case, how we educate sites to make sure that they know that participants should still stay in the trial. We should still collect data from them if they do stop treatment. It's worth saying, I think some of you may be aware that Will Cragg from Leeds has sort of got a little group of people from across the CTU network looking at withdrawal and sort of participants stopping involvement in studies, and is producing some guidelines, and this covers site training, it covers protocols, it covers patient information leaflets and stuff. So I'm not sure when that's going to come out, but it's in process at the moment, so there may be some guidance going around CTUs looking at this on a broader scale as well.
And I think that point you just made about the presumption of what withdrawal means, that it's meaning something wider, I think it taps into a potentially quite a delicate situation, in that we all are aware that it's important not to pressure participants in any way. I interviewed a woman some years ago for a qualitative interview, and she was eligible to take part in my interview because she was the mother of a child who had died after being recruited to a clinical trial. And she'd actually had twins. And what she asked was that her surviving twin be removed from the trial because it was just too emotional to have the two babies were both in the trial and one had died. So she asked for withdrawal. But what she didn't want was to not contribute data from either of the babies But that is what actually happened. The surviving baby and the deceased baby's data were completely removed from the trial, and that was clearly not her intention at all. So it may be that actually by being overcautious about what withdrawal means, or assuming that it means that the participant wishes a larger withdrawal, that data is being lost unnecessarily as well. So that's a possible area to consider too, I think.
Yeah, I think there's definitely, from my perspective, there's definitely a lot more research that can be done at understanding what participants know about withdrawal, what they know about retention, because obviously this is all from a research perspective. I think it would be quite interesting to think about what they know about, how much they care about retention from their perspective, because you know, we know from a practical perspective it is really important. What would happen if a participant knows it's important? Does that affect the likelihood of staying in the trial? Does it feel, how do we communicate it without feeling coercive, so that we know if they have to stop, that's absolutely fine. There's no pressure to continue in the trial. But if you're uncertain and you know you want to contribute to the trial and you want to make a contribution, then these are the ways that you can do it.
Yes, having an explicit point at which you have to make a decision about what happens now, what happens with your data, is part of making that all very clear, isn't it?
Yeah.
Somebody's asking if you could put up your penultimate slide again, Anna, just so that the publication details are available.
The recommendations or the
publication details?
The publication details, there you go.
That's really helpful.
It's +1 in 2018.
Yeah. Okay. There is one other thing that I'm quite keen to get your views on, because it's a subtle situation. You started to talk about it a little bit, which is the situation of the potential participants who enter a trial with a half plan or even an actual plan of withdrawing if they don't get their preferred treatment. And whilst that's a problematic situation, we do actually also have a statement, as you put up, that they can withdraw at any time. So addressing that, is there a way that the patient participant leaflets can head off that potential problem, or is it something that we just have to accept, especially as some of those participants may not withdraw?
I think with everything it's a balance, isn't it? And it'd be interesting to see what other people think. But I think you have to communicate participants with right to withdraw. They have to know that. And in many cases that helps people feel confident to engage in a trial. But I guess the main message, what I'm trying to communicate in this work, is that it needs to be balanced. So we do need to think about how we are helping people know the problems that occur if they do end up dropping out, because then they can make an informed decision at the consent process. So an example might be, I know someone that would happily be involved in research, very pro-research, would do anything, but actually their lifestyle is incredibly busy. They're never in one place at a time. They're not very on the ball at getting to different appointments. That actually they might admit themselves that they would probably not turn up and do half the things of the trial that they would want. And I think it's helpful to try and think about, well, in those circumstances, how do we help people understand, and work through that decision, should I participate or not? A lot of our metrics are so keen on getting participants in trials and, getting that first patient in and getting, meeting our targets, meeting our numbers. And I think it's a balance of trying to recruit people, but also making sure the people we recruit are likely to be retained, and how we help people think through that process. And obviously circumstances change, and that's absolutely fine, and you can be committed to starting a trial thinking you'll finish it, but actually something changes and you need to stop, you move away, you have unexpected events in your life, side effects, etc., and that's fine, and you drop out. But perhaps there's some sort of thinking through what's in the patient information leaflet. How do we help people understand that this is, once you sign up, it is a benefit to stay in the trial where possible, and not to take the decision to withdraw lightly, And it's a careful balance because, as you rightly said earlier, there's lots of concerns in this area about coercion. And I think that's perhaps why there's very little content in these patient information leaflets about retention. People play it safe. They stick to what your rights are, that you can withdraw. But actually, I think we need to start in our research, working with our PPI advisors, our PPI groups, thinking about, well, how do we balance this information? How do we address, the need to communicate to people that there is a benefit in withdrawing, and there's a benefit in continuing within a trial, and withdrawing does cause problems. That should stop you withdrawing, but it should just, help you think through the process.
There's several times when I've been sort of doing different pieces of research where I felt that it's come back to the same issue quite often, which is that it's really important to make trial participants feel that their contribution is important and is valued. And I think that's part of it, that they're contributing really important, valuable data, and the trial teams value that data and are thankful for them doing it. So whether you're thinking about communication of results, or a reason for participating, or a reason for staying in the trial, I think making people feel that their contribution is important and that their individual questionnaire is valuable and is needed is potentially quite an important angle that we could take, and is very positive too. Okay, so we have one more question, and then I think we'll be almost out of time. I think our follow-up calls at every 3, 6 and 12 months have immensely helped patients to make informed decisions to continue providing us questionnaire information, even if they have withdrawn from treatment. So that comes from Manmeeta, who's sort of talking about direct contact with participants. It's a comment, really.
Yeah. And there's lots of, I guess you rightly say as well, we've looked at the whole withdrawal process at consent and retention at consent, but there's talked about the fact about what you discuss at consent as well. But you rightly point out there's also, consent is an ongoing process, and so a lot of this information is relevant throughout the trial as you connect with people, have phone calls with people, collect the data in terms of checking they're still happy to be involved, and again that creates an opportunity to ask if there are any problems and to address those at an early stage as well.
Yeah.
So, yeah.
Always good to address at an early stage. Thank you very much, Anna. That was really useful. I think lots of practical information there, and somebody's been asking about tweeting the information. So if you have a hashtag that you want to share with us for people to tweet, please do put it in the comments box, Anna. Thank you, everyone. Rionfa has asked me to remind you all that when you leave the webinar, there's a feedback form, and it would be really helpful to have that. There's a link in the chat box which you can follow. We do really value that feedback, and it gets reported at meetings, so it would be very helpful to know what you think, and also if there's anything that you would like to hear in the future as the webinar series continues. So we'll wind up now. Thank you very much, everybody, for coming along and for chatting, and thank you, Anna. Thank you also, I should say, to Rionfa, who's provided huge technical support and will continue to do that. Thank you all. Bye.